Now today discuss about the neural tube defects. Before starting the discussion about the neural tube defects, we should know something about the embryology, that is how the central nervous system is actually getting developed. This is our ectoderm and this is endodermal structure, and in between we have a mesodermal structure. This is ectoderm, this is endoderm. We have notochord here, and this notochord keep on stimulating this part of this ectoderm, only this part, and that leads to thickening of the ectoderm locally, and this thickened part is actually termed as neural plate. The rest part of this ectoderm is actually surface ectoderm. Under the influence of notochordal stimulation, there is progressive invagination of neural plate structure, progressive invagination of the neural plate structure, and eventually it invaginates further as well and leads to neural groove formation. This is our notochord. This notochord keep on stimulating this part. This is neural groove. In between the surface ectoderm and neural plate, there is one structure which is mesodermal in origin. This is called as neural crest cell. This neural crest cell is actually mesenchymal or mesodermal in origin. That eventually form your peripheral nervous system. And of course, we do have mesoderm here. This part is actually mesoderm. And this is your endoderm. From this, now we have ectoderm here, and our neural plate structure basically separates and goes inside. So this is called as neural tube. And we do have our neural crest cell structures. We have notochord here, and we have endodermal structure here. And by the side of the notochord, we have paraaxial mesoderm followed by intermediate mesoderm and lateral plate mesoderm. This is paraaxial mesoderm. This is intermediate mesoderm. This is lateral plate mesoderm. This is intermediate mesoderm, and this is lateral plate mesoderm. Of course, this is our endoderm, and also this is our ectoderm. Now suppose this is our neural tube structure, and this is the neural tube structure. This is cranial part. This is caudal part. They eventually form our central nervous system. This cranial part is actually forming the cerebral part, the upper part, and also this caudal part basically forming the spinal cord as well as the cerebellum, this part. And this, and we have this neural crest cell. Now the neural crest cell derivatives are leptomeninges, your Schwann cell as well as peripheral nervous system. These are neural crest cell derivatives. Leptomeninges, peripheral nervous system, and also your Schwann cell, which basically leads to myelination of peripheral nervous system. So this is another picture of neural tube. This is your cranial part of the neural tube. This is caudal part of your neural tube. This is called as anterior neuropore. And this is termed as posterior neuropore. Anterior neuropore actually closes by 23rd day of intrauterine life, and posterior neuropore actually closes by 27th day of intrauterine life. Suppose this anterior neuropore closes normally. Now the remnant becomes lamina terminalis. Remnant is lamina terminalis. This part of your, actually this is lamina terminalis part. If it doesn't closes, then the anomaly is anencephaly, which is not compatible with life. Suppose this posterior neuropode doesn't closes, it leads to spina bifida. So another thing to remember from here is, this is your neural tube structure. Suppose your anterior or posterior neuropode doesn't closes, that leads to basically uh, trickling of alpha fetoprotein and acetylcholinesterase into the amniotic cavity, and that can be diagnosed during pregnancy. That is alpha fetoprotein from the pores which are going into the amniotic cavity, and your acetylcholinesterase. These are used as a diagnostic test to diagnose neural tube defects during pregnancy. Though we use imaging studies, that is ultrasound, still we can use this alpha fetoprotein or acetylcholinesterase as a marker. Now discuss about the risk factors for neural tube defects. The most important risk factor is folic acid deficiency. It can occur due to hyperthermia and also some anti-epileptic drugs. These anti-epileptic drugs do have some anti-folate effects. That is the reason they are basically important risk factors like valproate, carbamazepine, and phenytoin. We have some maternal risk factors as well. Maternal obesity is a very important risk factor, and maternal diabetes, which is overt and uncontrolled. We can have some genetic risk factors like some genetic mutations like 510 methylene tetrahydrofolate reductase enzyme mutation. This genetic mutation is also very important as suppose in the first child is having some neural tube defects, and also in the second pregnancy the chance of having neural tube defects becomes 3 to 4%. In the third pregnancy it becomes 10%. This gradual increase in the chance of having neural tube defects in the same pregnant woman basically defines that there could be some genetic mutations underlying it, and which is most commonly 510 methylene tetrahydrofolate enzyme, reductase enzyme. So you are discussing about the neural tube defects. If the posterior neuroport doesn't closes, it leads to the defects, which is basically spina bifida defects. The spina bifida defects could be spina bifida occulta or it could be aperta. Occulta means the skin is intact, and aperta means it can be seen from outside. So we have spina bifida occulta. The spina bifida occulta may be of two types. One is called as simple variant and another is occult spinal dysraphism. And this is basically your simple type. Here the spinal cord is present inside, and also the posterior vertebral arch structure is absent. That is the only issue which is covered by muscles, subcutaneous tissue, subcutaneous fats, and skin. But inside the spinal cord is absolutely normal. So the main defect you can see, the posterior arch is not formed. This is normal, but this is abnormal. This is the reason for spina bifida occulta. There is failure of maturation of posterior vertebral arch structure. This is essentially a normal structure. But the, another subtype of spina bifida occulta is occult spinal dysraphism. That means the defect is occult, but inside the spinal cord there is some anomalies or some malformations involving the spinal cord, and there are some indicators of it. If this hemangioma or this hyper, and this is the picture showing the occult spinal dysraphism. And occult spinal dysraphism means from outside it is occult, but inside the spine there is some malformations involving the spinal cord. In case of occult spinal dysraphism, from outside we can see hemangiomas. This is hemangioma, or we can see hyperpigmentation of skin. or we can see some tail-like appendages plus lipoma. This is tail-like structure or and also associated lipoma. And here we can see tuft of hair. In all these conditions where we can see all these things from outside, it becomes an indication for doing MRI to know as if there are some spinal dysreflections, that is, some malformations involving the spinal cord is present or not. So in these cases, the investigation of choice becomes the MRI. We can see some another example of here is some lipoma, and in the MRI you can see in the MRI we can see this is the lipoma part, which is involving this spinal cord as well as going outside, involving this part as well. So there is lipoma outside, but as well as it also involves the spinal cord. That is, some spinal malformation is also present here. Now let's discuss about the spina bifida apart. So these are example of spina bifida apart. We have meningocele, we have meningomyelocele. In meningocele, there is swelling of this part which can be seen from outside. There is swelling of this part which can be seen from outside, and this is like a soft fluctuant mass we can see. This is a soft fluctuant mass which can be seen from outside. In meningomyelocele, there is also the soft fluctuant mass, but the difference is in meningomyelocele, the spinal cord structures are also present within this seal, that is the cavity, fluid filled cavity, that is CSF filled cavity. But in case of meningocele, there is no invagination of the part of the spinal cord into this fluid filled cavity, and this is a basically transillumination test becomes positive in this case. Transillumination is also positive here. So if the meningocele, if this meningocele is covered with skin, there is no threat to the patient usually. If the meningocele is covered with skin, there is no threat to the child. So suppose it is covered with a thick skin, therefore, and also no neurological abnormalities associated with, immediate surgery is not required. Suppose this is covered with thick skin and on examination no neurological deficit, no immediate surgery is required, no immediate surgical intervention is required. But whereas suppose this is covered with a thin skin or there is leaking CSF, that is, suppose CSF is leaking from this structure and also it is covered with a thin skin, so it becomes a serious threat and also therefore immediate surgical intervention is required, neurosurgical intervention is required in this patient. So now discuss about the meningomyelocele. This meningomyelocele is the incidence of this meningomyelocele is actually 1 per 4,000 live births. And of course, the high risk factors involving this that we already discussed earlier. That is our folate deficiency and some genetic causes like 510 methylene tetrahydrofolate reductase enzyme mutation, or it could be some anti-folate drugs, that is anti-epileptic drugs like valproate, carbamazepine, and phenytoin. Some other drugs that do have, and we do have some other drugs that has anti-folate activity like trimethoprim. All this. So this meningomyelocele, the most common location is lumbosacral region. The lumbosacral region. In this, in meningomyelocele, as there is invagination of the spinal cord structure within this cystic space, it is usually associated with some neurological abnormalities. This is associated with some neurological abnormalities like bowel and bladder dysfunction. We have bowel and bladder dysfunction, and also there is perianal region anesthesia. And on neurological examination, we also find the deep tendon reflexes becomes reduced, or sometimes it becomes absent, or and also bilateral lower limbs there is flaccidity, and also this is associated with some lower limb abnormalities like club foots. So the treatment option for meningomyelocele is surgical repair, is basically surgical repair, and also proper follow-up after that, and other deformities like club foot may be there, so proper orthopedic care should be taken for this. Orthopedic treatment and follow-up should be there. After that, let's discuss about the prognosis of these patients. Prognosis of these meningomyelocele patients. All suppose there are all patients, and 85 to 90% patients basically survives, and also only death is seen in 10 to 15% cases. If proper treatment is given, 85 to 90% of patients basically survives. And this 10 to 15% patient, there is death. And out of all these patients, the 70% patients actually have normal intelligence, and 30% patients, there is associated infection which is going and involving the brain, that is associated meningitis and also ventriculitis is present in this 30% case. Ventriculitis. And because of this meningitis and ventriculitis, there is low IQ in this patient, and also cognitive function is reduced. So basically, uh, in the 70% of the patients, there is normal intelligence, as there is no associated meningitis or ventriculitis. But in these patients, there could be associated some association with some seizure disorder later on. And also in this 30% of this patient, as there is associated meningitis or ventriculitis, it is associated with a low IQ or low cognitive function. And that is all about your prognosis of this patient. Now let's talk about anterior neuropode. Suppose there is anterior neuropode associated neural tube defects. If the anterior neuropode is not closed, so the most significant defect is your anencephaly, where the brain substance as well as the skull is not formed. Usually, your brain substance is not formed, but cerebellum part as well as the spinal cord is usually present in this patient. Here you can see the cerebral part is not formed, this part, but the cerebellum as well as the spinal cord structure may be present. And this is called your encephalocele. Encephalocele. Cele means cystic space. And the most common site of this cystic space is actually, you can see, that is occipital region. And there is another abnormality which is called as anencephaly. In anencephaly, there is severe retroflexion of the head. You can see there is severe retroflexion of the head, as well as there is fusion of the cervical as well as the upper thoracic spine. And you can see, and this child do have a specific gauge. It's like star gauger. Now, this is the USG, and here you can see this is typically seen in anencephaly. So this is the USG where we can see the two orbits. This is one orbit, this is another orbit, which basically looks like a frog eye. So this is called as your frog eye sign. And essentially the brain structures are and the brain parenchymal structures are absent. This is your frog eye sign. This is also sometimes termed as Mickey Mouse sign. This is seen in anencephaly. Now you can see another example with meningomyelocele. Here you can see the cystic space along with the neuronal structure which is present inside that can be seen. This is your anencephaly.